Thank you very much, Professor K. Carr, and it is a privilege to be part of the Garfield Steering Committee and to discuss this afternoon atrial fibrillation burden, morbidity, and mortality. Here are my disclosures. I'm going to start off giving you 2-year outcomes from the first 2 of the 5 cohorts in Garfield AF. And here we see that the largest threat to these AF patients is death. They have a high incidence of death of 3.8 per 100 person years. The second biggest threat to them is the morbidity of congestive heart failure. And third is stroke and systemic embolism. What we found when looking at the 2-year outcomes in Garfield AF is that over the first 24 months of follow-up, there is a sharp uptick in mortality and morbidity during the first 4 months, with a 29% increase in mortality during the first 4 months compared with the first 24 months, a 35% increase in stroke during the first 4 months compared with the entire 24 months, and a 56% increase in major bleeding during the first 4 months compared with the first 24 months of follow-up. This sharp uptick in mortality was first hinted at some years ago in the Framingham Heart Study in the age group of 75 to 94-year-old volunteers for this study, and those patients with atrial fibrillation, men and women, compared to those patients who did not develop AF, shown below, had a very sharp increase in their mortality within the first few months of being diagnosed with atrial fibrillation. A more recent study published last year looking at almost 9,000 patients with atrial fibrillation found again that total mortality is the biggest threat during the first 10 years of follow-up, and cardiac death accounted in this cohort for more than half of all deaths. Then there was heart failure as the #1 cause of cardiac death, followed by stroke. When we look at hundreds of thousands of patients in the U.S. Medicare database, and this comprises patients who are primarily 65 years of age and older, both outpatients and inpatients, we see during 5 years following the diagnosis of incident atrial fibrillation, death is the #1 problem, followed by heart failure, both in outpatients and in inpatients, and then myocardial infarction, stroke, and gastrointestinal bleeding in outpatients and in inpatients who are hospitalized. Here we see the pivotal trials of the novel oral anticoagulants against warfarin that were used for approval of the 4 novel oral anticoagulants. And what we're looking at are the causes of death in more than 6,000 of these more than 70,000 patients who were enrolled in these trials. And we see that stroke accounts for 5.7% of all the deaths, and cardiac deaths comprise about half the deaths in these patients with atrial fibrillation. When we compare the direct oral anticoagulants against warfarin alone, the most striking finding is a 50% reduction in fatal bleeding with the DOACs compared with warfarin alone. Now, it's important that we do everything possible to prevent morbidity and mortality in these AF patients. And our mission statement is that the first mission in AF patients is to prevent stroke. There's overwhelming data in favor of this primary mission statement. And how do we assess who is most likely to suffer a stroke? We have the CHADS-VASc score, but coming into the forefront of our focus is the power of elevated cardiac biomarkers, D-dimer, high-sensitivity troponin, and pro-BNP. And the higher the quartile abnormality of elevation of these three biomarkers, the more likely these patients are to die, and the more likely these patients are to suffer a stroke. Let's look at patients with a very high CHADS-VASc score between 5 and 8 who have a low biomarker score shown in this pale blue, and let's compare their rate of death and stroke with patients at the other end of the scale with a low CHADS-VASc score but a very high cardiac biomarker score. And you see that these patients with a high biomarker score with a low CHADS-VASc score have twice the rate of death and stroke compared to patients with a high CHADS-VASc score but who have a low cardiac biomarker score. Where do women fit in compared to men with respect to the burden of atrial fibrillation? Well, for reasons that we do not understand, in Garfield AF and in other registries, women have a 30% increase in stroke compared with men. Their overall mortality and the major bleeding rate in women, as we find in Garfield AF, is similar to that of men, but the stroke rate is 30% higher. Well, let's look at the anticoagulation. Do women receive different anticoagulation than men in Garfield AF? They do not. Their rate of receiving warfarin, antiplatelet therapy, NOACs, and no anticoagulation is really the same as that in men. And I will tell you that the quality of anticoagulation with warfarin in terms of the target INR was the same for women as for men. And what about different types of atrial fibrillation? How do they impact the burden of AF morbidity and mortality? When we look at permanent AF, paroxysmal AF, or persistent AF, we really find no significant differences among these three types of atrial fibrillation in terms of outcomes of stroke or major bleeding or all-cause mortality. A very hot question, one we're going to delve into more during our panel discussion, is whether atrial fibrillation is primarily a risk factor for stroke or a risk marker for systemic diseases such as heart failure. If we look at the ASSERT study, where patients had long-term cardiac monitoring of their heart rhythm, 51 of these patients developed ischemic stroke, and 18 of these 51 patients had subclinical atrial fibrillation recognized on monitoring before the stroke. But let's delve a little further. Only 4 of these episodes of subclinical atrial fibrillation prior to stroke occurred within 30 days of the stroke. So we have these two different concepts. If atrial fibrillation is primarily a focal electrical disease, we would expect the rhythm treatments to lower stroke, and we would expect a close temporal association between the development of atrial fibrillation and the development of stroke. What's gaining our attention is the concept of atrial fibrillation as a marker of risk for systemic vascular disease, with contributions from obesity, metabolic syndrome, sleep apnea, diabetes, hypertension, and a sedentary lifestyle, in conjunction with a hypercoagulable state caused by atrial fibrillation, where the risk of adverse outcomes persists despite good treatment of rhythm, and with a poor temporal association between the development of atrial fibrillation and the development of stroke. Take-home messages are that AF is a risk marker for systemic disease and a risk factor for stroke. And our first mission in AF patients is to prevent stroke. Heart failure is a more common cause of death than stroke in these patients. Elevations of D-dimer, troponin, and BNP are more predictive of stroke than the CHADS-VAS score. Women receive equal rates and quality of anticoagulation as men, yet for unknown reason, their risk of stroke with AF is higher than that of men. Finally, integrated care of atrial fibrillation requires patient involvement and empowerment, educational guidance, and shared decision-making. Thank you very much.